All right, so this month with Stretch Effect, we are doing men's health. And men's health is inclusive of many things, one of them being prostate and prostate cancer. Luckily today we have a medical specialist, Dr. Schwartzberg, also known as Rocco, but he is the prostate MRI guy. And his focus for some of his studies and his work is around early detection for prostate cancer. Ross, can you explain a little bit about that for us?
Sure. Well, thanks for having me. It's nice to talk to you. Yeah, prostate cancer is a common cancer. It's the most common cancer in men outside of skin cancers. So it's we're all at risk. All guys as they get older are at risk for it. So the key is general principle in oncology and cancer treatment is the earlier we find it, the better. And that's been a controversial area for many years on how to best do that. It turns out that using MRI imaging is really a key, and that with the PSA test, which is a blood test that many of you have probably heard about, using those two together is probably the smartest way to go about determining if a guy who's considered at risk does in fact have a cancer, and if so, what to do about it. Okay, so we all know people, right? Men, husbands, fathers, brothers, people that are in our lives that can be affected by this conversation. There seems to be some disparity in the field between how someone might go about detecting whether or not they have cancer. And when we hear the word cancer, cancer is a really scary word, right? But I think there needs to be some depth to that conversation, understanding are all forms of prostate cancer severely deadly, and of people who do have prostate cancer, how many of them are really deadly affected by this prostate cancer? Outstanding question, really gets to it. So although prostate is a very common cancer, the incidence is high, but the aggressiveness of the most common type of cancer is low. So what the key for screening is to find the important cancers and not find the unimportant cancers. Unfortunately, if somebody tells you you have a cancer, the discussion about how aggressive it is and what the natural history is going to be sometimes gets lost because you're focusing on that word cancer. Yeah. So the key at the very front of the pathway is to first find a method that's most effective at finding the important cancers that need to be discovered and therefore then need to be treated. At the same time, not finding the unimportant cancers, which unfortunately can roll out then to the man having therapy that may or may not, in fact in most cases, does not improve their life, yet subjects them to harms that come along with treating the gland. There's those gland functions we're very interested in preserving that are at risk if you get treated. So yeah, the key is how do we find these important cancers that need to be detected and treated and not discover these unimportant cancers. And the best way to do that, and this is based on multiple international studies, is to use the PSA test, that blood test, but before you go straight to the biopsy, which has been the standard pathway up until recently, and still is occurring in many places, is to go straight from a blood test, which is not very accurate. It's not very specific. It's got a very high false positive rate. Yep. Going from that test to another test that's fraught with all sorts of problems, that's the systematic blind biopsy, where needles are just put into the prostate.
And when we talk about needles, how many needles are we talking about here?
Well, the standard would be 12. That would be the minimum, would be 12. 6 on each side of the gland, and some places do more. And unfortunately, that itself obviously is not without side effects. A little bit, but it's not just pain.
And that's kind of like just stabbing in the dark. Yeah, hoping you find something.
It is. It's a poke and hope. It's literally a blind biopsy. You know you're in the prostate because we're using sound wave imaging, ultrasound. to make sure the needles are going into the prostate, we can't distinguish normal tissue from possible cancer tissue on the ultrasound. So it's been a very, very kind of somewhat barbaric way to do it. Fortunately, like I mentioned, because of all these multiple international trials, we do have a better way. It's slowly becoming adopted. So if a guy out there is considered to be at risk, and that would be based on his age, his ethnicity, African American men are nearly at twice the risk of getting aggressive cancer. Caribbean descent African men are also extremely high risk. So guys, those guys probably should start to be thinking about screening in their 40s. If your father or brother or some close family member has cancer, it puts you at a significantly higher risk. Prostate cancer is probably the most heritable of the diseases, meaning there's much more close association between a close relative having it and you having it. And so those are the genetic factors that you can't do anything about. At some point we'll shift to the environmental lifestyle factors, which really we can do something about and do, on the one hand, stem the aggressiveness of a cancer if you have it, if you adopt
mitigating some of the progressive nature of the cancer.
And at the same time, it's preventative up front. So if you adopt the healthy lifestyle that makes you look good, feel good, that you're an expert in, it also is very, very protective for your prostate.
Okay, so just gonna table that side of it on like the what we can do side of it. So let's talk about the process, like for a traditional person, maybe some people may not understand how this works, right? So either I'm of said age, which would indicate I'm probably gonna go get a prostate screen, is this correct? And or I'm exuding symptoms. Are these kind of the two ways?
So I'll take the second first. Truth is, prostate cancer almost never gives you any symptoms. If it's giving you symptoms, it's really, really very, very progressed, and there's nothing we're going to be able to do with it other than what we call palliate, which is to treat your symptoms and make you comfortable. So we don't want to wait till that. So that gets to
that would be too late.
That's too late. So then it gets to what do we do, and the answer is there is a protein that's called prostate-specific antigen that's put out by the prostate gland, and we can detect it in the blood. The problem is it's put out by normal prostate tissue, non-cancerous tissue, as well as cancerous tissue.
So almost normal.
So everybody's going to have a PSA. The question is, what's an alarming number?
The reading.
And because we were in the last 30 years going straight from that reading, that whatever we considered, mostly it's anywhere from 2.5 to 4 over those. If it was over that level, the man would be directed to this biopsy procedure. Both of those immediately, without taking a look, and that rolled out in such a dismal way that the harms were greater than the benefits, and in such this audience may or may not have heard of the United States Preventative Task Force panel, which looks at screening tests.
And these are just medical procedures.
They look at medical procedures and specifically tests to early detection. And they gave, and this is controversial, very controversial, but they gave the PSA to biopsy pathway a D rating, basically saying don't do it. And that's really dramatically impacted what's happened in the last 10 years. And like anything, we've kind of overshot. We really kind of put a stop to the PSA screen. Many of the primary care doctors would no longer offer it to their patients, or they'd say, well, there's...
Because of fear of running into this ramification of the biopsy.
The biopsy, and then what we call the overtreatment. So these guys were getting these cancer diagnosis with the lowest grade cancer, which we subsequently learned that really don't harbor any risk to the guy's life unless he lives to 150. And we don't live to 150. So it's called clinically insignificant cancer. It looks like a cancer under the microscope, but does not act like a cancer. And there's
The way that it proliferates.
Exactly, the way that it doesn't proliferate, the way it doesn't signal to the other cells and doesn't spread outside the gland, etc. Totally. But those guys were going on to treatment, and that means either getting their gland removed or getting the gland radiated, and the gland functions, which we're talking mojo, or more commonly known as erectile function and dysfunction and continence. So being able to control your
so there should be
bladder.
like somewhat daily function, normal function for said individual is now being completely obliterated, just in case they might have like a serious form of cancer, which you were telling me is a low probability chance that even if they do have a form of cancer, that it's a aggressive
and this, again, and these are all literature, scientific, data based.
And we can post references to all of these types of things to make sure that we can do our checks and balances on those.
And I think one of the common, when you first start medical school, the term "first do no harm." Any intervention has potential side effects.
Totally, double-edged sword. Double-edged sword.
And what we were causing too much harm and gaining too little benefit with that standard screening
process.
Blood test straight to the biopsy pathway.
Now, in your world, you work part of like Imaging Healthcare Solutions, and you are a trained neuroradiologist, but have specialties outside of that. And you guys focus on some preventative imaging through MRI. Is this correct?
Yeah, so what we've learned based on all these studies and our experience locally, which now is almost 10 years and literally thousands and thousands, 10,000 cases, is that if you use MR as a triage test, so that means a guy who's 40, 45, he's got a family history of prostate cancer, he wants to screen for it and find it early, which is what we would all agree makes sense. He gets the PSA. We know the PSA, it's considered to be at a level that's a concern. The first thing you do is you repeat it because one data point isn't enough. PSA levels can bounce around related to activity, diet, inflammation, etc.
So we would need two, at least, maybe three.
At least two. We'd have to see a trend. If that trend
and over like what period of time? Like how much time in between?
We're probably months. So we wouldn't want to. We're talking weeks.
Not alarming. We're not running.
No.
Right. We're just getting a test, finding a data.
Correct.
Going back a few months later, getting a test, finding a data.
Right.
Seeing if we're finding similar things, worse things, better things.
Exactly.
Correlative.
Right. And if it looks like the trend's continuing, and then the smart way to do it is then do you go to the MRI? Now the MRI can tell you all sorts of stuff. It can tell you the size of the gland.
Which is indicative.
Which is, the larger the gland, the higher PSA level you can have. Because
just naturally.
Yes. And here's the interesting thing about the prostate. One guy can have, prostate the size of a ping pong. And the next guy can have the prostate almost as big as a bowling ball. One guy can have a 30 cc prostate. The other day I saw a guy with a 400 cc prostate.
Well, just naturally.
Just naturally. That's because of their hormones, their genetics, whatever. So you can imagine the guy with a bowling ball size,
spectrum there.
He can have a higher PSA level.
But not scary. Because it just has a bigger prostate.
And so we correct for that what we call PSA density. But we can determine that with the MRI. Bottom line, with MR, about 40% of the guys that come to us, we can say, listen, there's no evidence of cancer. Your PSA level's high because you've got what we call benign enlargement, BPH, that can affect your ability to empty your bladder and cause symptoms that way, but it's not cancer and you don't need a biopsy. So you're
not going to die from that.
You're not going to die for it.
You might have some urinary issues, things of that nature.
And we could discuss, or the specialist would discuss the options for that, which is, again, lifestyle modifications, maybe some therapeutic medicines, etc. But you don't need to go sticking a needle in, which is a big, big win in itself. Okay, I would say.
I don't know that I'm signing up for that
Right.
Okay, so we have different people at different sizes, which can kind of skew a PSA test, which could be alarming in certain circumstances. And then with the MRI itself, we're going to see size of prostate, which could be indicative of problem, no problem, depending on anatomy, etc. But then what else can we kind of see or do?
We can determine the size, but then we can also find, is there what we call tumor suspicious area of interest or region of interest? Is there a target that has all the features of a cancer on MRI.
So you can actually see a picture that shows tissue, different tissue, healthy tissue, cancerous tissue, essentially.
That's right.
To each other.
So Zach, my son, he makes jokes about what I do as a radiologist. It's you go to the California Pizza Kitchen, on the menus they have like the pirate there, and then the other pirate, and they look the same, but find the 10 differences.
Yes.
One's patch is different. That's what I do. I'm wicked good at finding what's different and stuff.
Yep.
So we can see the cancer looks different. Obviously, there's layers of that you learn over time, but now I can draw a map around it, and now we can target a needle. Yeah, we can do a precise biopsy, put the needle exactly in.
Now that's under MR?
So there's different ways of directing the needle. We do it, we've done thousands of MR in-bore, we call it MR in-bore biopsy. There are other ways of doing it. If you can call it cognitive fusion. So you know the cancer is in the anterior left side of the gland. So when you're doing the ultrasound, you direct the needle that way, knowing there's a technology where you can take the MR data and fuse it onto the ultrasound. So when the urologist is in his office,
they're literally seeing.
Yeah, they can, which is probably the most common way now.
Okay.
But the key is you now have something like
it's directed.
You're a gun guy, don't you always like aim first? I thought that was part of it.
First. Yeah.
So we're aiming now, and obviously the yield we're going to hit it because we're aiming.
Yeah.
So we're enriching our biopsies. So those we didn't talk about the 1,300,000 guys that go to biopsy every year in this country, and 200,000 have cancer, which means you do the math. 900,000 biopsies don't need to be done, or they're missing the cancer because they're just randomly sitting. Now we're going to enrich that because we're going to put the needle in the right spot.
Yeah.
So that happens about 40% of the time.
Okay.
But 20% of the time, the guy, like any test, sometimes we're not sure because there's an overlap between the pirates look very similar. I can't really tell. Meaning there's some inflammation.
Other
factors of the gland itself, of the technique, or of the cancer. Some cancers are spread out. They're not all bunched together. The cancer cells, if they're all bunched together and of a certain size, we can see that with imaging. If they're spread out and have normal cells in between, and then cancer normal cells, that's called tumor sparse. We're not as good. So we don't do as well. The sensitivity drops for us. So in those cases, if the PSA density, which is
super high,
then we say, listen, MR has not solved the case. We're still worried about this guy. Now
we got to go back to that old.
Yeah, we go back to the biopsy. But we've already you've
exhausted, and you've accounted for 80% of the population.
Yeah. So it's a win-win. It's a win.
So it's good because there's different types of prostate cancer. Right, there wouldn't just be a single form of prostate cancer when someone says that.
That's correct.
And then different size anatomy, right? So it's understanding that we have to be fairly proactive in this conversation. We should be somewhat educated in this conversation. This is our anatomy, right? And then we can kind of help guide this process a little bit. And one of the things that we talk about here is kind of you should be your primary healthcare provider in the sense that you ask questions, you're dictating and driving the ship and the narrative as to what is exactly happening to your body or whom is doing anything to your body for that matter.
Absolutely, and I came into medicine with that as my background as a sick patient. The term doctor, the Greek derivative is teacher. We're supposed to be help guiding you. There's a push now with everything in the world to collectivize everything and treat everything the same way. What's called population medicine. One way to do it, I would say, as opposed to what we used to call a holistic approach. When you train your clients, you don't have one program for everybody.
Right.
I mean, you assess them, you find out what they need.
Right.
It should be the same dynamic with a physician and patient, and that means engagement by the patient. Right. You have to educate yourself. You have to use the doctor or whoever as a resource to educate you, but don't just
checks and balances on the information.
Right, and make sure you're engaged and you're participating actively. It's going to be a better outcome.
Yep. Now, that's like kind of the process that someone would go through from start to finish if they were going to have engagement with, prostate cancer or concerns around that. Now, when we talk about prevention, right, because we're big on prevention here, right, because being a proactive person versus a reactive person yields much better outcomes long term, right, and mitigates the severity of said instance when it does occur. So when we talk about preventative things that individuals can do for prostate cancer, what is that realm and what does that look like?
Well, what's the better than early detection is preventative.
Right.
Is preventative health, and two main big factors for why does one guy get a cancer and another guy doesn't. One, it's your parents, it's your genetics, which we can't change. However, we can affect the genetic expression based on the environment, which means our lifestyle, which means our activity level and our nutrition. So even if you're born with the genes, an imbalance of genes, which puts you at a higher risk for prostate cancer, if you eat right, and we'll probably go and look at the different,
talk about some specifics
which is plant-based diets and Mediterranean type stuff, staying away from inflammation, stay away from high sugar.
Processed meat, staying away from processed meats, anything that would be pro-inflammatory.
Exactly. That absolutely, there's very solid data now that is preventative, decreases your risk of getting a cancer, and at the same time, if you have been diagnosed, there's very good evidence that adopting these lifestyles, diet, nutrition, exercise versus the inactivity and overeating, etc., you are going to mitigate and decrease the progression of your cancer that you already have. So you can
actually slow it down too.
Right.
While everyone's trying to figure out where it is and what it is and how bad it is and all of those types of things, you can take actionable items to immediately suspend or delay some of the progression, and outcome measures can be positively impacted.
Exactly, and at the same time, you're going to feel better. You're going to,
There's intrinsic, extrinsic value to this. And so, I mean, I think that's one of the things, and we speak about this a lot here, understanding, a lot of people can have why, you have somebody who's talking about I have plantar fasciitis, and why won't my plantar fasciitis go away? And then it's I run out of energy at the end of the day, and it's so I lose motivation to do my stretches, and then it's, why are you running out of energy to do your stretches? And it's because I don't sleep well. Okay, why are you not sleeping well? Oh, because I'm watching TV and I'm watching all the stimulating things before bed, and I don't have the right environment set up to allow my body to rest fully. So it's getting back to the root cause of some of the lifestyle behavioral facets, which can indirectly affect the issue problem that might be at hand. In this instance, might be some sort of prostate issue or cancer, God forbid, or if we had even something simple as a musculoskeletal issue, right? Understanding that there's a ripple effect that takes place.
And since we're talking about it, and I don't want to miss this point, is that the guys that have prostate cancer, the overwhelming majority of them will die with the disease, not of the disease. And the things they're going to be dying of are the more common lifestyle-related things: cardiovascular disease, heart attack or strokes, diabetes, it's liver disease. So it wins on every level, and really it gets back to those behaviors that we all struggle with, is persistent, consistent, and
it's not short-lived, it's not a fad diet.
No.
Right? These are things that are extrapolated over years and decades to create true impact, and to not allow genes to, as we get towards those end of the telomeres, they don't turn on.
That very impressive telomeres, that's right. But you're absolutely, epigenetics, it's called. It's a fascinating thing, and you're absolutely right, and it gets to the whole motivation. You can't wait till you're motivated. While you're doing it, you can then think, okay, I'm motivated now. And you guys are the experts at helping clients do that.
No, it's great. It's great, Ross, and I really appreciate you taking some time out today to help inform. We will be able to have some Q&A questions by the end of the month that we'll maybe try and go through as well.
Sure.
So we'll try and propose some questions to see if there's some specific things that people have that we can potentially allow some more clarity around. Next, I think we're going to go over some of the like health, wellness, behavioral things that we can look to implement, and what research is telling us seems to be the most directly beneficial for this concept, so that we're not getting too far off in the weeds. But we'll talk about dietary things that can absolutely help with prostate and prostate health.